Great to be back with all of you. And here we go. I love talking about intestinal permeability because, as we mentioned yesterday, this is such a critical area for us to focus on when we are working to determine what's going on in the gut and how is that impacting systemic disease and as well as local inflammation and disease. So the question is, does somebody have increased intestinal permeability? Do they have leaky gut, right? Or do they have increased intestinal permeability, which is the official name? And how do you know if they have it? And what can you do about it? And that's what we're going to delve into over this next hour and a half. Okay? It's such an important leverage point for our patients, really. It can really help us when we focus on, is there increased intestinal permeability, and focus on healing it. We can really work to lower inflammation in the local gut as well as the whole body. So during this lecture, we'll talk about what are the antecedents, triggers, and mediators of intestinal permeability or increased intestinal permeability, how bacteria may promote or inhibit both local inflammation and systemic inflammation. How do we reveal or track intestinal permeability with testing if you choose to do it? And what other GI tests can you look at? Just to orient us, yesterday we showed you the IBS clinical decision tree. And remember in that organized part, when we're organizing it around that dig-in framework, we've got all of those things that may contribute to symptoms of IBS and intestinal permeability. It can be related to all of these things, from digestive insufficiencies to dysbiosis to SIBO to adverse food reactions. So sometimes a food like gluten can cause increased intestinal permeability, but many times, because there's increased intestinal permeability, people are reacting to many foods. And so that's when we're going to be like, okay, we've got to pay attention to this and work to heal that increased intestinal permeability so people aren't so reactive to foods. So that first I in the dig-in model is intestinal permeability, and it can often influence that second I, the immune modulation and inflammation in the body. It's also important to remember that increased intestinal permeability can occur even when people have no GI symptoms and they have no signs of irritable bowel syndrome. So though we're talking about it in this context of IBS, there's many times where people will have increased intestinal permeability without any GI symptoms, as well as without IBS. So I just wanted to clarify that so we weren't confused. I love starting with the case, so here we go. This is a 30-year-old woman who came to see me with mixed connective tissue disease. And mixed connective tissue disease is an autoimmune disease that has overlaying symptoms of scleroderma, lupus, rheumatoid arthritis, and polymyositis. So when I was gathering her information here, you can see on the right it says go to it, but we're at the G is highlighted. This is the information we were gathering. 30-year-old woman, mixed connective tissue disorder. At the age of 13, her elbow locked up playing basketball, but then it resolved. But then a month later, she had her finger swelled up. That also resolved as well. At 20, she had swine flu, and there was a lot of stress going on with her mom's cancer. And she felt that those two things may have been triggers for her inflammatory autoimmune disorder. And soon afterwards, she was diagnosed with mixed connective tissue disorder. Over the years, she was on and off medications, methotrexate, Cellcept, Enbrel, Rituxan. Cellcept worked the best for her, though it did result in some GI symptoms. And she notes when she came in to see me that she intermittently had flares in her muscles and her joints of inflammation. She would get flares of fevers and ulcers in her mucosal membranes in the esophagus, mouth, and vaginal area at times. So when I filled out her matrix, this is what I filled out for her. Remember, when somebody comes in to you with autoimmune disease, you want to go upstream. You want to try to figure out what the root causes of their autoimmune disease is. And that doesn't mean we can always figure it out, but we want to be thinking about that, because that can help us determine what we need to change, what we need to adjust so their body can heal. So there's this triad of autoimmunity. We're going to talk more about that. But when somebody has a genetic predisposition, increased intestinal permeability, and then a trigger. And I always sort of write this down for my patient, right? I will explain to them, we are dealing with this triad of autoimmunity. And if we can work to remove a trigger and heal increased intestinal permeability, if it's present, which it often is, then we can work to calm down autoimmunity. It doesn't mean we can always completely remove an autoimmune disorder, but often we can calm it down and help the body heal. And there are times, sometimes when something reverses itself, you will see that as well. And people who are on medication can go off medication or can use less medication, right? And the other thing we're focusing on is what can we do to prevent an autoimmune disease or multiple autoimmune diseases from getting worse. So I think those are the things I'm thinking about. And I work through this with my patient when I show them the matrix and we talk about where we are going to focus. Okay. I talk about, let's determine if there's any triggers and work to heal intestinal permeability. Okay, so this is her matrix here. You see that she has a strong family history of, or she has a family history of autoimmune disease, a maternal grandmother with RA. She had, difficult time growing up with her dad's alcoholism and her mom's cancer. She felt, as I said, the triggering events was the swine flu and the stress in her life. Under nutrition, under these lifestyle factors below, you see she's got some food sensitivities that were checked in the past to gluten, soy, peanut, and cashew. But she was not, when she came to see me, 100% gluten-free. She was eating gluten a couple times a week. She noticed that gluten would cause a lot of GI issues, bloating, even some sort of body pains and headaches. But, she had tested negative for celiac, and so she was not 100% gluten-free. The other things I want to just point out up here in her clinical imbalances, we see there's a lot under defense and repair, as we might expect in this area, right? She's got autoimmune disease. She's got a history of asthma, urinary tract infections, antibiotics for that, yeast infections, acne, steroid use. And then under assimilation, we see a lot too. She has a history of heartburn. She was taking omeprazole when she came to see me, some bloating. Her bowel movements were pretty regular. There wasn't a lot of toxin exposure that we gathered on her history. And that is something I always pay attention to with autoimmunity, because when we think about different triggers for autoimmunity, we think about, gluten, we think about toxins, we think about dysbiosis. Those are some of the things that I'm really focusing on paying attention to. Infections. Okay, so I chose to do a test to look to see, does she have increased intestinal permeability? I was wondering, is there increased intestinal permeability, and is this leading to some of her autoimmune disease? Is this an area we really need to focus on for healing? And so I chose to use this lactulose mannitol test, and I'm going to go through different options for testing during this lecture. But I chose this test because she was on CellCept, and I was not sure if the CellCept, as being an immunosuppressant, if it would decrease antibody production in her body. And another way that we can check for intestinal permeability is looking at antibodies against zonulin and lipopolysaccharides and actomyosin, and I'll show you that later. But because of my concern with her medication, I chose to do this test that's been around a long time, the lactulose mannitol test. And what it tests for is if lactulose is absorbed too much, and lactulose goes paracellularly through between the cells. And if there's too much lactulose that gets absorbed and released in the urine, then that's a sign of increased intestinal permeability. So it looks at amount of lactulose in mannitol and the ratio, and you can see here that she has an increased ratio, which is a positive test. In addition, we look to see, okay, does she have celiac disease? Dr. Hanaway will be going through gluten testing later today. How do you rule out celiac disease? How can you react to gluten? But what I did here is I did a genetic test and I did the standard celiac panel. And you can see here her standard celiac panel is negative. She's got a total IgA that's normal and her antibodies are in the normal range. What you'll notice here under the genetic testing is this looks at a few of the genes, or the genes that are involved or associated with increased risk of celiac disease. And I like how when this lab reports it, I think it's very helpful, because what we know with celiac disease is about 1 in every 100 people have celiac disease. And so it's 1 in every 100. And so what this test will look at is, given your genetic makeup, what is your individual risk, right? So with her, she is positive for both of the HLA-DQ2 genes. And as a result, her genetic risk is 1 in every 35. So I explained to her, if there was 35 people in a room, one would have celiac, statistically. But for the general populations, it's 1 in 100. So she does have an increased risk genetically. That does not mean that she will definitely get celiac, but it does show that she has an increased risk genetically. I did go on and do some further gluten sensitivity testing. And this is a test that looks at multiple different antibodies against multiple different proteins in wheat and gluten. And the idea of this test is, can we pick up celiac disease early or show some signs of wheat gluten sensitivity early? And I was really surprised that even though she was on an immunosuppressant, she had a really high reaction. This is a very positive reaction to gluten on this test. And remember, we made the point that gluten is one of the foods, or really, the main food that we know that can actually increase intestinal permeability. A lot of the other food reactions that we have are the result of, because somebody has increased intestinal permeability, they start to react to a lot more foods. But gluten is actually one of those foods that can trigger increased intestinal permeability. Okay, so here are her biomarkers, the ABCDs of nutrition assessment, and we see that she had some low amino acids on serum amino acid testing. Her omega-3 levels were low. For carbohydrates, she really didn't have any imbalances there. She was low in iron and had anemia. Her vitamin levels that we checked were pretty normal, and her oxidative stress marker, the 8-hydroxydeoxyguanosine, was slightly elevated. I put that under P for the polyphenols. And she does have active inflammation. Her SED rate is high at 55. These are her plasma amino acid levels, and you can see here they're all low. And when I see that, it makes me go back to my lecture yesterday and wonder about how is she digesting and absorbing her protein. First, of course, you wonder, is somebody eating enough? But then also, are they digesting and absorbing it okay? In addition, we did urine testing on an organic acids that did show some high indican, which can indicate high levels of bacteria. And her stool testing showed low levels of butyrate there at the bottom, which can indicate low levels of good bacteria, because remember, the good bacteria are producing these short-chain fatty acids. And this test also, the culture showed some bacterial overgrowth. So some signs of dysbiosis on testing. So I'm going to have you guys think about this during the next hour of this lecture. What would you do next? What's your diagnosis and what's your treatment plan? Of course, I'm going to circle back to this and review this with you at the end, but just think about it as we go through more information about intestinal permeability. So let's first talk about those antecedents, triggers, and mediators of increased intestinal permeability, right? That first I in your dig-in model. Yeah, so we've seen an explosion of articles on intestinal permeability in PubMed. So, I always talk to patients about, okay, yes, leaky gut is something we'll use as a term, but the official term is increased intestinal permeability. Let's start with the polling question. I want you guys to list one cause of increased intestinal permeability. Remember, if there's more than one word, then put a hyphen in there. So I want you guys to kind of give me some ideas of what may cause increased intestinal permeability. Yeah, we start to see here diet. We talked about gluten. Absolutely, gluten can be a trigger for increased intestinal permeability. Alcohol is definite. When people are drinking alcohol, that is inflammatory, but also it can result in people having a poor nutritional intake. So that we see that a lot depending on the amount of alcohol we're talking about. So sometimes alcohol intake is associated with malnutrition, and that can be, of course, a sign of a cause of increased intestinal permeability. Okay, what else is going on here? Everything's coming up. Infection, 100%, NSAIDs, stress, traumatic brain injury, toxins, celiac disease, antibiotics. You guys are great. Glyphosate, did we say glyphosate already? Yes, glyphosate. As you know, some people are questioning the concern around gluten or wheat for some people, maybe because of the glyphosate triggering increased intestinal permeability. Toxins, heavy metals, not having enough fiber, processed food, sad diet, Roundup, which is glyphosate, fast food, bad food, crappy food. Sorry, I'm adding my own words in there. Okay, dysbiosis, malnutrition, restricted eating. I'm just going to add some more there. Medications, NSAIDs, aspirin, ibuprofen. Okay, so here are what are some of the triggers of increased intestinal permeability. And we talked about the food. We know stress, infections, dysbiosis, medications, all of those things can cause altered increased intestinal permeability. And then what that can result in is when there's increased intestinal permeability, foods that haven't been properly broken down yet, or food particles that aren't really meant to be absorbed or haven't been broken down yet will get absorbed into the body. There could be malabsorption and malnutrition, and an increased intake of toxins or these lipopolysaccharides, these components from bacteria or dysbiotic bugs can get absorbed into the body, and that can trigger an immune reaction, right? And that immune systemic reaction can be anything from an autoimmune disease to eczema to inflammation in the body. Okay. So as you've seen, there's thousands and thousands of articles that have been published on increased intestinal permeability. Alessio Fasano really consolidated this concept in 2000, and other related terms include leaky gut, autointoxication, and endotoxemia. But we've been talking about increased intestinal permeability for years in functional medicine, and the literature has as well. Here, this is back 30 years ago, really talking about how intestinal inflammation enhances mucosal uptake and systemic distribution of potential injurious macromolecules. This is not a new concept. Here, 15 years ago, really highlighting the fact that an intact intestinal barrier is critical for normal physiological function and disease prevention. So, we know that the permeability in the gut is really critical for prevention of disease and continuing to prevent inflammation systemically as well as locally. So the pathophysiology of a number of diseases is associated with dysfunctional intestinal barrier. And, we know this is critical. We have a lot of our immune system surrounding our digestive system, and that is because we are exposed inside of the intestines. This barrier is exposed. The inside of our intestines is exposed to tons, 3 to 7 tons of food in our lifetime, and that can, has a huge antigenic load, more antigenic load on a daily basis than our immune system, our systemic immune system sees in a lifetime. That food is full of antigens in the food particles, as well as bacteria, molds, viruses. And the immune system in the gut has to really decide what is okay and what is not okay. And so that it has a lot of work to do. We want it to be doing the work as correctly as possible. And that barrier is made up of there's a physical barrier, a chemical barrier, and an immunologic barrier. So the physical barrier includes that intestinal epithelium, that cell layer, as well as this mucosal layer on top of it, and all of the good bacteria. That is that physical barrier inside the digestive system. There's also a chemical barrier, right? We have cells that produce these AMPs, antimicrobial peptides, that come from lysozymes and defensins that will find abnormal things and get rid of them. And then we have an immunologic barrier that includes the secretory IgA and other immunologic cells, dendritic cells, macrophages. All of these things work to create a healthy environment in the digestive system. And, this is a really good slide just to sort of be able to visualize what I just said, right? You've got that one cell layer in the middle there with junctions between the cells, and see all those beautiful villi that are in the going into the mucosal layer. You've got those Paneth cells there that are producing the antimicrobial peptides, the beautiful mucosal layer on top of that cell layer. In there, you see those secretory IgA. Those are the blue X's, the secretory IgA, which is a really important part of the immune system in the gut. And then on top of that, you have all these good bacteria. And remember, the good bacteria in your gut and your whole body is really the first line of defense, right? It's a first line of defense in terms of the immune system. And then underneath in the lamina propria, we've got that immunologic barrier. You'll see the dendritic cells in there as well. So here's really a nice schematic showing a very healthy gut, where the lighter gray circles are things that we want to get absorbed, either transcellularly through the cell or paracellularly between the two cells. But those big blue dots, think of them as like toxins or food particles or bacteria that, food particles that haven't been digested properly yet, or bacteria that shouldn't get absorbed. You can see they're not getting absorbed there, right? But the gray dots are getting absorbed as they should. And another schematic, I actually printed this out and use this in my office to show to patients. Sometimes I'll draw it out too, but this is actually, once we got this beautiful drawing here, I'm like, actually, this is way better than my drawing of the intestinal barrier. So I think it's a great thing to show to patients when you can help them understand what you're talking about and show them like the tight junctions and how we want the cells to look on the left and right of the unhealthy cells there in the middle. And then showing both paracellular transport, which is between the cells. When there's leaky gut between the cells, it's going paracellularly or transcellularly in through the cell. And you can have increased intestinal permeability both ways, increasing, allowing those lipopolysaccharides, the bacteria, the undigested food getting into the body when it shouldn't, and creating this inflammatory response. So this is a great thing to print out and just have available to show to people if you want that to do that. And then here is that same schematic, but just with not healthy, right? This is the leaky gut or the increased intestinal permeability, where, not only are those gray cells, those gray circles getting through, but the blue circles, those toxins, the undigested food, the bacteria are also getting into the body and have the potential to create inflammation. So we've talked a lot about this, the causes of increased intestinal permeability by infections and toxins and maybe glyphosate and poor nutrition. And then here showing you where that increased intestinal permeability can create inflammation. Now, I want to just point out one thing. It's not like the zonulin. The zonulin is a protein that creates and modulates the tight junction between cells. And it's important to recognize it's not like it's always open or closed. it's almost, think of it more like a dimmer switch. Of course, we want certain things to be getting into the body. And so it's actually complex. The body has a lot of things to think about in terms of what it wants to be getting in and what it shouldn't be getting in. And so it's not like any increased permeability is always bad. It's continued excessive increased intestinal permeability that can be pro-inflammatory. Okay, some other causes: alcoholism, strenuous exercise, nutrition depletion, bacteria, protozoas. We've got another polling question. Guys, get ready. Here we go. Name a systemic disease that you would associate with increased intestinal permeability. And remember, if it's more than one word, please hyphenate, because then it will make sense when it comes through. Okay, so think about a systemic disease. So you've got this local increased intestinal permeability. What can it cause systemically in the body? Yes, autoimmune disease, Hashimoto's, autoimmune thyroiditis, irritable bowel, yes, SIBO. Yes, irritable bowel. Long COVID, yeah, good question. Multiple sclerosis, obesity. There's a lot of research showing that when there is increased intestinal permeability and these lipopolysaccharides from the bacteria can get into the body, that is one cause of metabolic syndrome, insulin resistance, and obesity. Of course, it's not the only cause, but it can contribute, and something I'm definitely paying attention to. Arthritis, eczema, lupus, rheumatoid arthritis, urticaria, celiac, absolutely celiac, depression. Yes, it can, that systemic inflammation can trigger inflammation in the brain, and is definitely something we're paying attention to. Great. Okay, so we've got a genetic predisposition with an environmental trigger, with increased intestinal permeability, allowing for systemic immune response and initiation of autoimmune disease. So here, if we were to talk about celiac disease, and I sort of mentioned this with one of my patients yesterday. So if you have a genetic predisposition and then there's some environmental trigger, which for celiac disease may be eating a lot of gluten or having some gut infection, right? Or taking some antibiotics, and there's altered microbiome with local inflammation that can create this increased intestinal permeability, resulting in a systemic immune response and an autoimmune reaction, right? Like celiac disease. So again, the triad: you've got the genetic predisposition, you've got some sort of a trigger, and you've got the increased intestinal permeability. And I work that through with my patients all of the time. You've seen this slide already, but it's just to really reiterate the fact that these triggers, like improper diet, antibiotics, infection, can create this local inflammation and reaction, resulting in increased intestinal permeability, which allows food particles to get across when they're not supposed to, bacteria, toxins to get across when they're not supposed to, resulting in a systemic illness or autoimmune disease in some. Here, this is, really showing us molecular mimicry and cross-reactivity. Here is increased intestinal permeability. An antigen can get across, like a bacteria, creating an immune response. You see those T cells coming in and the B cells coming in, and those B cells form antibodies. And then sometimes the antibodies get confused. They're fighting off that antigen that's coming in, but there are some antigens in our own body that can look very similar. And so those antibodies get confused and start to attack yourself. And here in this situation, it's confusing with the cartilage in the knee, and you get an immune response in the knee, creating inflammation or maybe rheumatoid arthritis, right? Swelling and inflammation. So this is the concept around molecular mimicry, and the immune system confuses itself with non-self, resulting in the inflammation in the knee joint. And there's been a lot of, this has been really looked at throughout the years in terms of showing that antigens in the body can be very similar to antigens that the body is fighting off from outside the body. So like a bacterial antigen And so these translocation of antigenic and microbial components may create an antibody response that then can cross-react, or because of molecular mimicry, start to attack the body itself. And so we've seen that with Klebsiella and ankylosing spondylitis, right? So there's been some research looking at when people have ankylosing spondylitis, they have higher antibodies against Klebsiella. And so that may have been a trigger for that autoimmune disease. We've seen that with streptococcus and rheumatic heart fever. And we've seen that with Proteus and rheumatoid arthritis, or even gingivitis, porphyromonas gingivitis and rheumatoid arthritis. So there's many, many examples of when these bacteria can be triggers for autoimmune disease, especially when they get into the body when they're not supposed to, right? And so as Dr. Alessio Fasano says, reestablishing that intestinal barrier function is key to preventing or reversing or calming down autoimmune disease. And as I said, sometimes the body has gotten too far and we can't reverse everything, but we can really calm things down and arrest it for some people and reverse it for others and help support their body in healing. So let's describe how the intestinal barrier may promote or inhibit both local inflammation and systemic inflammation. So how that first eye is impacting that second eye, the immune system and the inflammation. You know, we know that there's chronic inflammation that can be healthy and important, physiologic inflammation that's really necessary for the maturation of the immune system in the gut. So not all inflammation is bad, we know that. And we also know that genetically, we all respond to inflammation in a different way for multiple reasons, right? We respond to different bacteria differently. So, and we can, how many antibiotics we've had over our lifetime, our genetic makeup, our good bacteria, our commensal bacteria makeup, all influence how we respond to disruptions in the balance in both commensal and pathologic bacteria in the gut. Of course, our diet, right? So there's a lot of things that impact how we respond. But we do know that excessive chronic inflammation is not good for us and associated with many disease states. And so we want to really think about what we can do to calm it down. So we want to think about foods, toxins that may be involved, stress, dysbiosis, and what we can do to calm down that inflammation they produce. I spoke about this yesterday, or started to speak about it yesterday, about these toll-like receptors, right? There's toll-like receptors in our digestive system that are determining, are sitting in there and determining what is normal and what is pathogenic, right? So what should I react to? What shouldn't I react to? And, that's an important part of our immune system, of course. These toll-like receptors act like gates or tolls for controlling the immune system. And they can look at the bacteria in there and say, okay, is this normal or abnormal? And what we do know, or what we've learned, is that in certain situations like Crohn's disease, there's a variation in the NOD2 portion of their toll-like receptor. I started talking about this yesterday. And so in people who have a homozygous variant in this NOD2 gene have a variation in their toll-like receptor in their gut. And as a result, they don't identify dysbiotic bacteria as well and get rid of it. And they also have a heightened immune inflammatory response when they see it. And this is the article that, this diagram from the article we're speaking about, showing that connection between our genetics, our environment. And then we're just going to sort of zoom in here and first look at the healthy side, where that NOD2 portion of the toll-like receptor is seeing abnormal bacteria and producing these antimicrobial peptides that will get rid of it as appropriate. And then in Crohn's disease, when there's this variant in that NOD2 portion, they have reduction in their sensing of these bacteria that shouldn't be there. And they also have, so as a result, they might get exposed, people with this variation might get exposed to a bacteria and not be able to get rid of it as well. And as a result, then that bacteria may create this feed-forward inflammatory response that then gets named Crohn's disease, right? So it's important to recognize that we're all different in terms of how we respond to our environment around us. Most of the time, the immune system's job in the gut is not to respond, right? 99.99% of the time, it has got to be recognizing the fact that things are all okay and I'm not going to overreact. And we do know that our good bacteria has a tremendous ability to influence this. And so we want to be supporting our good bacteria, of course. We know our good, healthy commensal bacteria can increase secretory IgA, which is a part of the immune system in the gut that's necessary for getting rid of unwanted bacteria. It can impact the inflammatory response we have. The good commensal flora can create a healthy epithelial barrier, and it is important for the maturation of dendritic cells and the Treg activation. Just showing you here, when we have a good amount of those commensal bacteria, all those different shades of blue up there above the intestinal barrier, that can help create all those healthy secretory IgAs, those X's, those blue X's, and improve the intestinal barrier there, the between the cells, and impact the immune activation and immune modulation. We're wondering, of course, if the fact that, we are not exposed to so many bacteria in our environment anymore, like if we're growing up not on farms and not having as much exposure to dirt, has that impacted the development of our immune system in the gut? And as I said, good bacteria really have been associated with, having the right level of good bacteria have been associated with less colon cancer and less inflammatory bowel disease, and can lower inflammation and improve in reverse increased intestinal permeability. We know that the good bacteria can create this biofilm in the gut, and that can help prevent unhealthy bacteria from getting in and creating inflammation. And we know that, the good bacteria, when there is inflammation, that will damage those healthy biofilms and create this feed-forward situation that we sometimes find our patients in. So yes, is inflammation linked to increased intestinal permeability? Absolutely. We see here on the left-hand side a healthy gut where there is, a good barrier function and good mucosal layer and homeostasis. And on the right-hand side, you see altered microbiota, lower mucosal layer, more inflammation, and yes. The answer is yes. So intestinal inflammation absolutely can create this systemic disease. So local inflammation in the gut can then go on to create systemic disease. Okay, so now let's talk about, now you're convinced, right? We've got to pay attention to the gut and is there increased intestinal permeability? But now let's talk about how can we monitor that? Can we test for it? We don't always have to test for it. We can sometimes just know based on symptoms. But if we want to test for it, how do we test for intestinal permeability? Is that testing helpful? And how can we track it over time? So in research, they will sometimes use this confocal laser endomicroscopy. And here, this is a research article looking at using CLE, because it gives you real-time evaluation of changes in the intestinal tissue and cells. And what was interesting here is they showed that food particles, food antigens, food sensitivities actually, because they weren't typical IgE reactions to food, but even food sensitivities could create real-time changes in the intestinal barrier by measuring CLE. So we do know that local inflammation can create increased intestinal permeability. as I started with my patient that we will come back to, I promise you, but when I started with talking about her, I showed you the lactulose mannitol test. This has been the most extensively used test for increased intestinal permeability, and it's clinically validated to measure small intestinal permeability. The mannitol is a monosaccharide that should get absorbed into the body through this transcellular, through the cell process. And that larger disaccharide, lactulose, diffuses between the cells, but we don't want too much of it to diffuse between the cells. If there is too much that gets diffused between the cells, then that it means there's increased intestinal permeability. So a high level of lactulose or a high lactulose to mannitol ratio indicates increased intestinal permeability. So here, when you get your test results, you see at the top, if you have a normal or high mannitol with a high lactulose, that means increased intestinal permeability. On the other hand, if mannitol is not getting absorbed as it should, if it's too low, that could indicate some malabsorption. The test is not perfect. The immunogens that we're exposed to in our environment are often a much different size than lactulose and mannitol. And what I feel clinically is that we do see some false negatives on this panel. Like if you get a positive lactulose mannitol test, then you know, okay, this person definitely has increased intestinal permeability. I feel clinically there are times when I'll get a normal, and I still think that we need to deal with an increased intestinal permeability. Okay, so here's just another diagram of these beautiful cells in our gut, that epithelial tissue layer. And you'll see here between the cells, there's a couple things to point out. Between the cells, you've got the tight junctions that are made up of the zonula occludens, right? They help regulate these tight junctions between the cells, so paracellularly. And then you'll see the villi, and underneath the villi are this actomyosin network. See the red hatches, like the lines, the red lines that are kind of like hatched? That's that actomyosin network. And I'm just pointing that out because there are some tests that will measure antibodies against that, and that can indicate some breakdown of the villi or the intestinal barrier. Because if that gets broken down, that can result in increased transcellular permeability. So zonulin is both an enzyme and a tissue protein, that signals the opening of the tight junctions. And high levels of zonulin have been associated with many inflammatory diseases, celiac disease, inflammatory bowel disease. But remember, zonulin, it fluctuates a lot. It fluctuates minute to minute, day to day. So direct measurements of zonulin, serum levels or stool levels of zonulin, are really just giving us one snapshot in time. And so as a result, they might not be the most accurate way to test. I think of zonulin as almost like blood sugar, right? It's going to go up and down depending on what's going on in the body. So a better way to test for is there high levels of zonulin all the time is to do antibody testing. Almost think of that like the hemoglobin A1C is to blood sugar. So blood sugar, depending on when you do the test, you might get a high level or a low level, but that hemoglobin A1C tells you what is your average amount of blood sugar over the last 3 months. Think of it the same way with antibodies against zonulin. Zonulin may go up and down depending on the time of day and when somebody ate and what they ate, both in serum and stool. But antibodies against zonulin in the blood may give us a much better idea of how often zonulin is going higher than it should be. So often when we're wondering about is there increased intestinal permeability, we're looking at antibodies against zonulin because they can be elevated for weeks at a time, and they can give us a better idea. So here's just some more research on antibodies against zonulin and how that can indicate there's increased intestinal permeability. We do know that these antibodies have been found to be high in people with celiac disease, for example. The other thing that is often checked for is antibodies against lipopolysaccharides. Lipopolysaccharides come from these abnormal gram-negative bacteria in the gut. So when you see antibodies against lipopolysaccharides, it tells you two things. One, it tells you that somebody has increased intestinal permeability because these particles, these lipopolysaccharides, are getting into the body. The other thing it tells you is that they have a dysbiosis potentially, that there's an imbalance in the gut bacteria and there's high levels of bacteria that are producing these lipopolysaccharides. So antibodies against lipopolysaccharides are telling us two things. We do know there's an endotoxin. In addition, you can look at antibodies against actomycin. Actomycin, remember those red hash marks that were below the villi? I'll show you them in a second. But the antibodies against actomycin can really tell us if there's been a breakdown of the villi and there's more transcellular permeability, if there's increased transcellular permeability. We do know that patients with celiac disease, for example, can often have the high antibodies against actomycin. So just to show you again, that actomycin, see it, those red lines below the villi, that if they're damaged when somebody has celiac disease, for example, the villi get damaged, the cells get damaged, and there's increased transcellular permeability. Okay, so let me show you an example of a test that looks at antibodies against zonulin, lipopolysaccharides, or actomycin. And here in this patient, there was elevated levels of antibodies against zonulin, indicating there was increased intestinal permeability and probably more of that increased paracellular and intestinal permeability. So we do need more research on this, definitely, but it can be very helpful if you choose to test or choose to track how your patients are doing or their level of intestinal permeability. And I'm going to show you more examples of this in the future. If you have listened to the pre-course webinar on GI testing that Dr. Messier did, a lot of this was reviewed. So I'm going to go through this area pretty quickly. And if you want to kind of delve into it more, go back to that lecture in the pre-course webinar on GI testing. But there are other things that we can look at in stool testing that can give us a sense of what's going on in the gut and is what's going on in the immune system in the gut, right? So we do calprotectin, lactoferrin, secretory IgA, lysozymes, and eosinophilic protein X. Now, calprotectin and lactoferrin for that matter, but I'm often checking calprotectin through a conventional lab as well, right? You can go LabCorp or Quest can do a stool test for calprotectin, and that is a good marker. And you'll also see it on your stool analysis, the comprehensive stool analysis that you do as well. So here, just to remind us that calprotectin and lactoferrin, they are markers of intestinal inflammation. They are telling us that there's inflammation going on in the gut, and that can be associated with inflammatory bowel disease, but it also goes up post-infectious. If there's cancers involved, infections, a lot of allergy and pancreatitis can all cause these to increase as well. Calprotectin is a very good biomarker that we're using often, and if it's greater than 200, you should, that's the red flag, and you want to say, I need to figure out what's going on here. I need to, if this person, it's maybe appropriate to send them to a gastroenterologist. Further testing needs to be done. There's concern that there may be some inflammatory bowel disease going on or some other process that is concerning, and we want to really evaluate. If they're less than 50, you're happy to see that there's not GI inflammation that is showing up with this biomarker, and that's very reassuring. And if they're having a lot of GI symptoms, that may point you more toward irritable bowel syndrome than IBD, right? That 50 to 200 is that in between, and that area is something I am following. So if somebody is has a calprotectin of 100, I am making sure through my workup and through our treatment plan that is going down to less than 50. I am following that to make sure that that's improving. If not, then they need a referral. So, there's a lot of evidence showing that calprotectin may be better than lactoferrin in terms of telling us about inflammation inside the gut. Secretory IgA is also a marker that you're going to see all the time on stool testing. And secretory IgA is giving us an indication of what's going on in the immune system of the gut. Remember that secretory IgA is one of the part of the innate immune system in the gut, part of the first line of defense in that mucosa in the gut. And so, we want to have a good amount of secretory IgA, but we don't want too much, right? It's like too little is maybe not a good thing, but too much is not a good thing either. And you can see here that it's that blue X that I've shown you many times that is produced in the lamina propria and goes through the cell and into the intestinal lumen to help fight off bugs that shouldn't be coming in or food particles. So here you'll see secretory IgA by this testing company that is low. And we're like, okay, what it's low is not good either, because secretory IgA is really important for preventing pathogens from entering the epithelial cells. It's got a lot of anti-inflammatory action, and it can help create homeostasis with the commensal bacteria. So we do know that secretory IgA increases when there is an intruder on board, right? A pathogen, a bacteria, a virus, abnormal cells, allergenic proteins, a lot of food reactions. But low secretory IgA may be an indication that somebody is not getting adequate nutrition or they're under a lot of stress as well. So it can influence the composition of the intestinal microbiota. It can downregulate a pro-inflammatory response. And it's really important for the body's, the immune system to work properly in the gut. So just remember with secretory IgA, too little is not good and too much isn't so great either. So as I mentioned, these are all different immunological markers, and this is delved into more in that pre-course webinar. So let's circle back with my patient. And this was that 30-year-old with the mixed connective tissue disease. And remember, we did the lactulose mannitol test for her. And we see here that lactulose was absorbed too much. So that's indicative of increased paracellular intestinal permeability. Her mannitol was absorbed properly, transcellularly, and so the lactulose mannitol ratio was elevated. And so I said, okay, she has increased intestinal permeability. You may have just suspected that, just given her illness and her symptoms. And you may say, well, why do I even need to do the test? Absolutely. You really don't have to do the test, and many practitioners do not. So don't feel like you always have to. But I'm just showing you a situation where we did do the test. And remember, she had increased intestinal permeability. We saw some gluten sensitivity. She was negative for celiac, but had a lot of reaction against gluten. And we also saw some dysbiosis. So I'm thinking for her, right, I'm going through that triad with her. I've said, you've got this genetic predisposition, you've got increased intestinal permeability. And then that third part of the triad is what was a trigger for her. And potential triggers may have been the stress or this dysbiosis, or maybe even gluten. So I wanted you guys to think about, what would you do next? What was your diagnosis of her, and what was your treatment plan? So I think you guys probably came up with that over the last 50 minutes, right? You got that all down? So here was my assessment, right? I said, okay, she's got mixed connective tissue disease with autoimmune disease. She's got increased intestinal permeability. She's got gluten sensitivity, so non-celiac gluten sensitivity. She was both reactive on testing and symptomatically. We also saw dysbiosis. She had an amino acid deficiency, which, made me wonder, was there inadequate intake, or what was going on with digestion or absorption? And was that because of local inflammation in her gut? She had some iron deficiency and omega-3 deficiency. We also saw some oxidative stress that may be a reaction to this ongoing inflammation in her body and in her gut. And she had inflammation with that ESR, her SED rate being high. So then I explained to her, really, we're going to work to heal that increased intestinal permeability and work to remove any potential triggers that may be going on. So I did a 5R program for her, right? Because I saw increased intestinal permeability and I know this is a framework that I've got to start with. So I'm going to do the 5R program. And so for her, we removed. So we made her 100% gluten-free. I'm like, listen, you've got significant autoimmune disease. You're really reacting to gluten. We know that gluten can be a trigger for autoimmune disease. I want you to be 100% gluten-free. And I explained that to her and she understood and she's like, okay, I can do that. I also made her low dairy. So we took her way down on dairy. I stopped coffee because I really wanted to help her get off those acid blockers. So I also removed caffeine and coffee and dairy to help her get off her acid blockers, because that was an important part of remove, because we know the acid blockers are probably contributing to this poor digestion of protein and not helping her gut heal, that's for sure. And then we saw that dysbiosis, this potential dysbiosis in her gut. So I did use an herbal antibacterial agent. I used one that had a combination of herbs and did it for about 6 weeks. But at the same time, I really replaced. So I gave her a digestive enzyme. I gave her some DGL and something that helped her break down gluten, that had DPP4 in it, that helped her break down gluten when she was eating out or she wasn't sure she could be 100% gluten-free. So I did replace. I wanted to calm down any inflammation she was getting from her food. I reinoculated with a broad spectrum probiotics, but I also really focused on the prebiotics for her. I gave her some pomegranate powder to help feed Akkermansia. I gave her some sulforaphane also to help feed the good bacteria in her gut. So a lot of these polyphenols, acacia fiber as well, and those prebiotics that Patrick Hanaway gave you so much good information about yesterday. And then we worked to repair, right? We made sure she was getting enough protein. Remember how many times I've said this yesterday? Adequate nutrition is critical for healing. So I wanted to make sure she was getting enough protein, enough calories, I gave her an amino acid complex to help with healing. In addition, on top of an amino acid complex, I gave her glutamine, because glutamine really helps with healing the intestinal barrier. And I gave her some zinc and vitamin A, also really critical nutrients for healing the gut barrier. I gave her omega-3s because of the anti-inflammatory properties, and she was low. I gave her some immunoglobulins. I used a serum bovine-derived immunoglobulin product that is dairy-free to help with healing the gut and improving the gut immune system, diet rich in polyphenols. And I gave her some butyrate, which is a postbiotic as well. We also focused on her stress reduction techniques, and I gave her some magnesium and 5-HTP to help with sleep and stress. And she also, remember I said she was having these chronic urinary tract infections, so I gave her some cranberry D-mannose to help break that cycle. And she was low in iron. And what we see, remember this was before treatment, and then after, there was improvement in her organic acids testing, the urine portion that looked at organic acids for dysbiosis in the gut. And this was 8 months later. So the question is, when do you check? When do you check to see if the intestinal permeability has improved? So how long should you wait? And it's a very good question. I mean, it definitely takes between 6 and 12 months to start to see a change. And some of my colleagues don't check very often, or many people don't ever check to make sure it's improving, and that's okay too. But here I checked her at 8 months, and we did see that's a pretty good improvement. So really, again, we're working to break that vicious cycle of increased inflammation and oxidative stress and systemic disease. And, this is really where a comprehensive elimination diet can be so impactful, because when there is increased intestinal permeability, when you remove foods and when you pull out the inflammatory foods, that can also help things calm down. Okay, so we're going to go through the 5R program even more specifically, right? So, I guess in a sense, more generally, I should back up. More generally, we're going to go through that 5R program. So what other things can you do when, I showed you what we did with her, but what can you do when you see your patient with signs or symptoms or testing that shows increased intestinal permeability, right? You can do that 5R program. And remember, pre-course webinar, Dr. Salt does a beautiful job going through this 5R program as well. As I told you, I always like doing a case, so I'm going to integrate a case into all the different 5Rs here and both tell you what I did with this specific case as well as what you generally can do with each of the 5Rs. So here's a patient who came to see me with hair loss and acne, and she was on spironolactone, and it helped with her hair loss and acne, but she was done with it. She's like, you know what? I want to just get this better without medication. She had been on antibiotics a lot in the past and Accutane for her acne. She was on birth control pills as well. And so she's like, what can I do with, a functional medicine approach to sort of improve this hair loss and acne? She came in, she was gluten-free, she was low in dairy. She definitely responded negatively to gluten. She'd get a lot of digestive issues, like she'd get cramping. And so she was really staying off of gluten. Okay, so here is her antibody testing. So we see here that she's got antibodies against zonulin, indicative of increased intestinal permeability, right? So I'm thinking, okay, she wants to do this without medication. She wants to improve her hair and her acne. And what can we really do to improve this intestinal permeability? So the first thing is remove. So for her, we removed gluten and dairy, and we also found that she had some dysbiosis on testing, which I treated. So I ended up treating it with both herbal and pharmaceutical medication. So, but what you can do when you're talking about remember, we're removing food sensitivities, intolerances, and allergens. And the idea is that this is for a period of time. Some of these foods you're going to be able to add back in. And so you may be just removing them for a period of time and able to add that back in the future. Other foods, for example, people who are really reactive to gluten, you may not be adding that back in because that may just cause more inflammation. So, but for a period of time you're removing, then you're doing, removing pathogenic microflora if you find it. You're removing any environmental stresses like pollutants, like glyphosate, so remove may also include removing the non-organic foods. So you can remove glyphosate and working to remove stress. So that may be that comprehensive elimination diet. That may be botanical or medications that are used to remove and put, removing stress and toxins from her as well, or one of your patients. So the second R, replace. So what I just wanted to highlight is that it's really important when you're doing this 5R. Remember I said that I often write it down on my patient's plan, and I'll say, okay, these are the 5Rs, but I'm gonna personalize it for you. And that's really important because you don't need to throw the kitchen sink in and do everything for everyone. You want to personalize the 5Rs. So it is from the testing and your gathering, you want to personalize it to what they need, right? So replace. Sometimes you're going to see that replace is a really critical area that you need to focus on, and other times maybe not. Maybe it's more just the remove and repair, for example, right? So replace, remember, includes the betaine HCl, bitters, digestive enzymes, the brush border enzymes for some patients, the bile salts. All of these things can be included in replace. And sometimes I'm using some digestive support. I'm replacing when people are having a lot of inflammation, but then I can remove that later on down the road. Or when their gut heals, you'll notice that sometimes they don't need all those digestive enzymes or betaine HCl as much in the future. And we see that all the time. So for example, when I was telling you about my patient yesterday who was on betaine HCl, and that was helpful for her, over time you may notice that they don't need it anymore, and you can wean down. Some patients, on the other hand, will always need a digestive enzyme. So it depends on the patient. Reinoculate. Really, this is how do you build up the good bacteria in the gut? And, everybody is different here. There may be probiotics that you're using. There may be, of course, the prebiotics that Dr. Hanaway really focused on yesterday, acacia fiber, the galacto-oligosaccharides, various fibers, soluble fibers in the diet. And for my patient that I showed you, we did a combination product that had some spore-based probiotics in it, a blend of probiotics, and I really focused on the dietary piece to build up the good bacteria with lots of prebiotics as well. Okay, repair. I think this is such a critical area that we need to focus on, because we want to repair that gut barrier so that you're not so reactive to foods over time. So this is when I always talk about, okay, we need to make sure that somebody has adequate nutrition, really important, adequate nutrition. And then this is a myriad of things that you can use that can help the gut repair, from glutamine, vitamin A, zinc, choline, which is really an essential nutrient to improve the mucosal layer in the intestines. Colostrum is used a lot as the serum bovine immunoglobulins that I've talked about before, omega-3 fats. All of these things can help with repair of the gut. For my patient, I did some glutamine, I did the bovine immunoglobulins, the serum-derived bovine immunoglobulins, I did some iron and zinc and omega-3s, and a real phytonutrient-rich diet. And then rebalance. Rebalance is an area we cannot forget, we don't want to forget. And for some of our patients, it's really the main area they need to focus on, right? That's where they need to make sure, okay, they're scheduling some relaxation exercises every day. For my patient here, we needed to make sure that she was doing at least 15 minutes of breath work in the evening to help with her sleep, or heart rate variability, mindfulness. IFM has a lot of great handouts in this area, so I encourage you, if you don't have those ready in your practice, download some of them, have them available, so it can make it easy for you to recommend this to your patients. And often then the patient takes the handout, they read it, and they're like, oh, okay, I can do this breath work. It's good to have that to give to them so they can add it in. So as I said earlier, you don't always have to check or recheck, but I did with her, and I'm just showing you an example of when we saw these antibodies start to improve at 7 months, and then another 8 months later, or in a year and a half after I started, they improved again. And so just to give you an idea of what we sometimes see, and she noticed that she was able to stop those medications for her acne and her hair loss, and her, things just improved, her digestion improved, and her skin improved significantly. So just, I want to just reiterate in terms of these 5 R's. You don't have to do them in order. You don't have to do them in order. You don't have to do all of them, and you don't have to do them all at once. And so you really want to focus on what's most important for that patient. And there's no right way here, right? I often, as I said, write it down on their plan and highlight where I'm focused, and that helps me organize my thoughts as well. You really base where you're focused on based on all of that information you've gathered or any labs that you've done. So how do you know if they're getting better, right? Maybe they're having less symptoms. Maybe their autoimmune disease has calmed down. Maybe their inflammatory processes in their body have calmed down. And you can also test, but you don't necessarily have to, that's for sure. Many times you just get a sense based on how they're doing that, you're like, oh, they're doing so much better, that they're not having as much inflammation. Their acne is improving. Their joint pain is improving. Their eczema is improving, right? So you can just get that feedback in that way. And what if they're not getting better? This does happen too, right? What if they're not getting better? You want to go back to their timeline, go back to their matrix, think about what could you be missing? Are you missing a dysbiosis that you didn't realize? Look at their food diary. Are they really avoiding all the foods you want them to? Or maybe they need to be more careful. Or are they not getting enough nutrition? Look at those ABCDs of nutrition assessment. Are they low in vitamin A because of either nutritional intake or for whatever reason? So really pay attention to both undernutrition, as well as, making the wrong food choices as well. So these are some things just to think about with the 5 Rs. So now I'm going to invite Dr. Hanaway and Dr. Lucchese back on, and we're going to do some cases.
Thank you. Are we ready? So thanks, Liz. I wanted to, I thought the whole thing was good. The last part in particular, that the 5 Rs there, you don't have to, what you said, throw the kitchen sink. And I thought you did a really nice job of, thematically, you should be looking at the 5 Rs, and there's no quote unquote right way or wrong way, but there is themes of, well, what's overall out of balance? What do you need to do? So you've already talked about that. I'm not going to ask you again about that, but Patrick, do you have anything to add to that in terms of how you use this concept of the 5 Rs?
Are we focused on the 5 Rs, or are we focused on permeability?
Right now, we're focused on the 5 Rs. We'll come back to
it's essential. It's the way in which to approach. So we dig in, and that's helping us to say, okay, where are we going to focus? 5 Rs are what we're going to do therapeutically and how to approach that. But I'm like Liz. I don't always do all 5 of them. I don't do them in order. I'm listening to what the patient's needs are and really be able to focus. And I find that you said people aren't always getting better. And so if they're not, like, what am I missing? I go back to the 5 Rs and I think about it. What did I miss? Or if things have changed, is there something more that I need to replace that I haven't focused on yet, as an example? So it's an iterative process.
Great. And in that concept, then how do you prioritize what obviously Liz has talked about for the past 75 minutes? How are you prioritizing intestinal permeability?
Well, the permeability issue is one that is common. It's something that we've talked about for a long time and is now in the literature as it's real. It's very clear that that's the case. It depends upon what's going on with the individual patient. So if they've got an autoimmune process, then I prioritize it very high early on. If they have a significant dysbiosis that's going on, then I prioritize that early. A lot of gut symptoms that are happening. Those are the two where I take it and have it be the number one or number two thing I'm focused on.
Okay. And so then, Liz, you had a really interesting poll about what do you think about associated with intestinal permeability? And one of the things that came up that a number of people, because it came up large, was long COVID. And we did a quick search of that, and it's interesting what we saw. And I'll let Patrick and I talked about it a little bit, and you can add what, in a quick search, very quick, was that there is an association with individuals who have intestinal permeability, and they do worse with long COVID symptomatology and actually also mortality. So if you have any thoughts on, have you obviously seen patients with long COVID? Have you done any testing with the intestinal permeability? What are your thoughts on that?
Yeah, I think there's a few reasons why that might be the case, right? So one is if you've got this increased intestinal permeability as your baseline, then you're in a more pro-inflammatory state in your body. And then that may, everything might be just feeding forward. And in addition, if there's the increased intestinal permeability, the immune system may be out of balance. So I think of those few things going on. In addition, some people are more just pro-inflammatory in general, probably based on genetics, and they may be, that feed-forward cycle may be causing the increased intestinal permeability and also resulting in them being more reactive in terms of COVID and getting long COVID. So I think there's probably a few things going on. Mm-hmm. That's what I think of.
Patrick, you talked a little bit. We talked a little bit.
Well, I think there's a couple things going on. One is that we actually see with the SARS-CoV-2 infection that there is a 20 to 40% increase in autoimmune disease, just in general. So we know that there's some permeability that's happening. We know that the virus itself, one of the mucosal places that it affects is the gut. And there's questions, is that the reservoir for long COVID hasn't been demonstrated to be true. But we do see that this increase in autoimmune processes is one of the sequelae of, post-acute SARS-CoV-2, so this PASC term that's used. Now, I think of long COVID as a little different, more related to the brain fog and the fatigue kinds of issues, and whether those are connected to intestinal permeability, not entirely clear to me. They're certainly connected to a signature of alterations in the microbiome, which is going to be one of the factors that's going to precipitate intestinal permeability. But what you saw in the review was simply, to me, stating people with intestinal permeability who get COVID and who have long COVID have worse symptoms and more morbidity, more mortality. Just makes sense.
Mm-hmm. Yeah, agreed. So we're going to go to a case here, and I'm going to read the case as I have. And then we are going to have some discussion. So this is a 63-year-old female, presents with osteoarthritis, osteoporosis, and depression. She's relied on nonsteroidal anti-inflammatory drugs, medications for the past decade, which have decreased her pain in her knees and hips. She's used a PPI daily for heartburn for the past couple of years, and has been on some medication for depression for 20 plus years. She passed medical history. She was colicky, raised on a standard American diet, a SAD diet, and has suffered from mild, moderate gas and bloating for most of her adult life. That's pretty nonspecific. So then the questions are, and I'll first throw it to Liz and then Patrick. The osteoporosis, osteoarthritis, depression could most likely all be related to, it's a leading question, and what would you do at this point? So Liz, why don't you start us off?
So they all could be related to, they're all inflammatory processes, so they could all be related to increased intestinal permeability. And, with the NSAIDs and the PPI, that could all contribute to increased intestinal permeability as well. And so, one of the things I'm thinking about is how can we lower inflammation in her body right away? And that's where I think the comprehensive elimination diet can be really powerful here. That can help with lowering inflammation. I think it can also help with us getting her off of some of these medications that could be making the situation worse. And we have a good handout with IFM in terms of how to wean people off of their PPIs. So that's probably where I would start.
Yeah, Patrick.
So they're interrelated, but the microbiome again. When we look at the history of her being colicky when she was young, a standard American diet is going to cause dysbiosis, seeing gas and bloating, seeing the PPI, which will tend to lead to bacterial overgrowth in the terminal ileum and decreased absorption of various vitamins and minerals. So I would be focusing not only on that, but on the microbiome and what can we do, and seeing, is there some bacterial overgrowth that's happening that we need to take care of and treat? What's happening with the dysbiosis that I talked about yesterday?
We did not treat the gut. I would say
that seems to work.
I made that up.
Did you?
Yeah.
Well,
I'm old.
Very old.
And then I want to say, and then I do want to add that we have a toolkit item on PPIs, on de-prescribing PPIs, and there's there are PPIs should be used short term. I think that's what what they have generally been suggested, recommended, and when we use them long term, there's a lot of problems with that you can look in the literature. A lot of problems with malabsorption and B12 malabsorption, all sorts of things. So there is good reason to try to de-prescribe
be prescribed.
Yeah.
And you can't just stop them acutely. You've got to taper it down.
Exactly.
Yes, because people will get their symptoms. They'll get a lot of acid reflux if you stop them right away, typically, especially if they've been on it for a long time.
Yeah. And tomorrow, Dr. Asmoah is going to talk about that in some detail. So we're not going to go into it now. So I'm going to turn it over to Liz, and you're going to present this case.
Okay, so this is a woman who came to see me, and she was frustrated with her weight and acne. So she was 20, she was in college, she had started birth control pills about 6 months before going into college, and she was had gained like 10 pounds. So her BMI was 24 about, so she was a little overweight. She had a fasting insulin of 17. But she was concerned about this acne and weight gain, and she wanted to see, okay, what can I do? So she was moody. She was not a big pill taker. She definitely had some, she was definitely a picker. So she would pick on her hair and her skin, some trichotillomania. And so I decided, I was like, well, let's see how much the gut is impacting your symptoms. And so I did a test for intestinal permeability on her. And so I wanted to show you that. So we can see here that she has antibodies against zonulin here. And, one of the things I didn't mention during the lecture is, of course, somebody's total immunoglobulin levels will influence the result of this test. So if somebody has a high production of immunoglobulins or deficiency, that's going to impact the results. And so you want to just remember that and take that into account, because that impacts whether they're going to have high levels or low levels. So I checked here to make sure she was in the normal range, and so that we could then feel like, okay, that was a real result. And so in summary, we said, okay, she's got high levels of occludin and zonulin, and she also just wanted to let you know that she had some gluten sensitivity. We did some testing, some food sensitivity testing, and we saw that she had some reactivity to gluten, to some grains on food sensitivity testing. We also saw some caseomorphins, which are these components from dairy that can cross the blood-brain barrier and cause some impact in terms of energy and mood. And so, that would be my summary here, that she's got some increased intestinal permeability and some food sensitivities.
So, Patrick, what else do you want to know in this case?
Well, I'll take Liz's line. What's her diet? What's she eating?
My line.
I've seen patients like this sometimes. What's their protein source? Are they vegan? What's going on there?
Yeah. So so great questions, because that's my line. I'm a nutritionist at heart, right? And so she was. She was in college, so she was grabbing food. She wasn't always careful. She was definitely eating gluten and dairy. And she was vegan for a period of time. And so one of the things we speak a lot about, I've talked about in the 5R program, is adequate nutrition. And so sometimes when we're gathering that information in terms of what somebody's diet, we're thinking about, are they getting adequate protein? Are they getting adequate zinc? Are they getting adequate, vitamins to help the gut heal, vitamin A? And so that was an area we really focused on with her. Yeah.
So go ahead.
Well, and then treating, right? Working with glutamine, other kinds of agents. How did you focus on the permeability issue?
Yeah, so we did the 5R program with her, and so we removed
personalized 5R, right?
Personalized 5R. So we removed the gluten and dairy, and because I wanted just to help her with weight and to help with lowering inflammation in her gut, and we also really focused on repair. And so with repair, we did, you're right, we gave her some glutamine. We really focused on the phytonutrient-rich diet that's going to be high in fibers and polyphenols that are going to help feed the good bacteria. And, I did also give her some zinc because zinc can help with skin turnover and it can help with acne. And so I gave her some extra zinc for a while. And she really, that helped her with managing her weight, losing a few pounds. She wasn't really a lot overweight, but it helped her get her weight under better control, and it helped her skin really calm down.
So I want to close with, we've talked a lot about, obviously, intestinal permeability, and I know you do a lot more testing around this than Patrick does. Can you just, in terms of reinforce the testing that you generally do these days for intestinal permeability? And we've already talked about, well, do you need to do it? How? But what do you do in terms of those tests that you talked about? What do you do regularly?
So, yeah, absolutely. The first thing I'm paying attention to are signs and symptoms and all that information we're gathering. So again, I don't think testing is not absolutely necessary, but when I do test, I'll do antibodies against zonulin and occludin and lipopolysaccharides and actomycin. That's typically how I'm testing, unless I'm concerned that they have a deficiency in antibodies or they're on an immune suppressant. And then I'm concerned that the testing might not be accurate, and then I'll go to the lactulose mannitol. So that's typically how I do it.
Great.
I totally agree. 100%.